I myself called this as a blockbuster session because the next four talks will be by the eminent personalities. To kickstart the session, it's my privilege to welcome our chief guest for today's function also. So, Padma Shri Professor Mohan Kameswaran sir. To chair the session, I request Professor Semana Selvan and Dr. Kumaran.
Good morning to you all, respected chairpersons and dear Shankar. First of all, my sincere thanks for asking me to be here with you all. It's really a pleasure. Shankar is one of my favorites, so it's a real joy for me to be here. I'll tell you later why he's my favorite, but he's my favorite. So today he wanted me to talk about an overall perspective about the changing philosophy in sleep apnea. To put it in perspective, so this 4 decades journey, I think I'm the only one in this crowd who has done this 4-decade journey. So, which is why I think I'm the only one qualified to talk about it. Yeah. So 1980s, I finished my MS from the very hallowed grounds of Madras Medical College, an institution which I still cherish with a lot of love in my heart and great pride. So in 1981, I went to UK after my MS. And I had the great opportunity to join one of the best institutes then in London, the Royal National Throat, Nose and Ear Hospital, which is the oldest ENT hospital in the world, incidentally, in Gray's Inn Road. And as my luck would have it, my very first consultant with whom I joined as a registrar was none other than Charles Croft. So you all have heard about Croft and Pringle. Pringle was then a senior registrar, and Charles and Croft and Pringle were then working on this sleep endoscopy. It was a completely new area for me, because Madras Medical College was doing a lot of good work at that time, but very good consultants. We did a lot of very good otology work, head and neck work. Rhinology did not exist then, but sleep was a totally new area, and for me it was a real eye-opener that we were starting a new discipline in ENT. Because I worked with him only for 6 months, but the 6 months was really quite an interesting period. And then, of course, I came back here in India in '94 after having spent some time in UK and the Middle East, Saudi Arabia particularly. And in '94, started the sleep department in Chennai, sleep center in Chennai. One of my early students is right here, Vijay. So when Vijay joined me, I was trying to put each one into one area, and I suggested to Vijay that he should take up sleep medicine. I know he was a bit confused in the beginning. He was not very convinced about it, because he wasn't sure how much of a future it held. But I had a very strong feeling that sleep medicine is evolving into something very major. And I think even my own expectations have been completely surpassed by what has actually happened. It's amazing the amount of revolution which has happened. And that's more or less what we are going to be talking about, because the philosophical change in the field based on scientific developments has been nothing short of miracle. So 80s, we had one surgery, uvulopalatal pharyngoplasty by Fujita. And for many of you, to know why the Japanese were the first, you should know that there was a very interesting event which happened. The Japanese Supreme Court had a landmark judgment when a lady applied for divorce on the grounds of cruelty because of husband's heroic snoring. Okay. And interestingly, the Supreme Court listened to his snoring and gave the judgment in her favor. So you can imagine what happened. There was a whole plethora of cases where a lot of Japanese women started applying for divorce based on cruelty because of snoring. So then came the dilemma of what criteria to set to define heroic snoring. So the Japanese Supreme Court called the Association of the Otolaryngologists and said, how do you define snoring, and what are you doing about it? That kick-started the first serious efforts, and that's how Fujita got into, fame, because he had developed the surgery of uvulopalatopharyngoplasty. And all of us, of course, we were thrilled. We all jumped into it. We had this fantastic operation where if somebody comes snoring, we tell them, okay, we'll stop your snoring. So uvulopalatopharyngoplasty was, and it's basically a simple operation. Anybody could do it. So it was very nice. And then, of course, in the 90s, it's very soon, in fact, even the 80s, it became apparent that this is not the way forward. That there's going to be a lot of failures, people coming not at all happy after the operation. So in 90s, in Stanford, Riley, Paul, and Gilliman also, they came up with the Stanford protocol for skeletal framework surgery. So they said there's no point just sitting and operating on the soft tissue, but you have really got to move the skeleton to create space. And this was a real game changer. Immediately we understood that a lot of patients were actually patients for skeletal framework surgery. So this was the next major step, I think. And also, soon enough, we understood that just operating on the soft palate alone with just excision, creating more space. The concept was that you have a narrow space, make it bigger by taking out a lot of tissue. Caused a lot of other morbidities. And therefore, the concept of reconstructive surgery rather than destructive surgery. So that's how, we had, all the other surgeries, expansion sphincter pharyngoplasty, and braided, suture, reconstructive surgery, and TORS. So all this started coming in the 2000s. And then a decade later was a more scientific approach to it. Eckhart and colleagues from Australia started looking at the physiological thing, and Kashmira today brought it out very nicely. She pointed out all the the issues in the physiological endotypes. And finally now, of course, we are on to precision airway surgery, where you are giving individualized surgical care. So it's a huge shift in philosophy from one surgery does it all to look at what each person needs and then try and do what that person needs, surgical or non-surgical, whatever. So to understand the concept of airway collapse, one of the first things we all learned the hard way was that it is a dynamic challenge. It's not a static problem. It's a dynamic. It's constantly changing in the patient. The velum and the palate, those showed a lot of changes. The lateral pharyngeal wall will be collapsing, and that would alter. And in fact, one of the major causes of failure in UPPP. Tongue base in different formats, it could either be a volumetric increase in tongue base because of lymphoid hyperplasia, the soft tissue, or a posterior displacement of the soft palate, of the tongue. Epiglottis in various, shapes. I remember a very good lecture once, I think about 10 years ago by Srinivas, showing all sorts of epiglottic variations. I still remember that lecture, right from a trapdoor to a floppy epiglottis, to a omega epiglottis and so on. And finally, the hypopharynx itself narrowing due to the position of the hyoid. So all this we realized are dynamic situations. So then came the palm concept, where there was a pharyngeal critical closing pressure, which is basically the anatomical determinant of collapsibility. So narrower the anatomy, the higher the closing pressure. And then the respiratory arousal threshold, which determined how often the patient was waking up. And the loop gain, which based on the ventilatory control feedback. And finally, the muscle responsiveness, the upper airway dilator during the sleep apnea and during the sleep obstructions. And this is where the recently developed hypoglossal stimulation is now becoming a big issue. So all this had to be integrated in the assessment, and then we had to develop a dynamic strategy. So soft tissue surgery had a reconstruction, or had a transition from the classical era, which I talked about, which is basically UPPP, to the ablative era. So once the UPPP came, then modifications using the laser. Kamami came up with the laser, and then the radio frequency, where they said, okay, minimal tissue excision. You don't want tissue loss too much, just what is required. And then, of course, the coablation, cold tissue ablation. And then even that was not good enough. So then came the reconstructive era, where you had the expansion sphincter pharyngoplasty by Kenny Pang and Powell, where they just displaced the palatopharyngeus muscle laterally, and then the braided suture repositioning surgeries by Vicini and co-workers. So all this was more in favor of preserving the structures and reconstructing the structures rather than excision of structures. So there was a phenotype driven interventions. This is what Kashmir pointed out this morning. So you looked at what anatomical problem was there in the patient, and your surgery was targeted towards that anatomical problem rather than looking at a big colossal intervention. So basically from enlarging the airway where we started, we have now started looking at stabilizing the airway. So that's the change in philosophy, and I think it is a very important change in concept. So today we have a lot of soft tissue work in the palate. So you have expansion sphincter pharyngoplasty, barbed reposition pharyngoplasty, I already talked about it, functional expansion pharyngoplasty. And the clinical application is mainly when you are looking at the lateral wall collapse without any very major skeletal abnormality. So it's mainly a soft tissue work. The skeletal framework looks fine, and you're only looking at the lateral pharyngeal wall as a main collapsing segment. Next came the tongue base, and this is another new area for us. So you had suddenly the tongue base becoming a very important factor. It was collapsing, causing obstruction. And so we started off with coablation, of course, to reduce the volume of the tongue base. Then came SMILE, the submucosal lingual excision, where you preserve the mucosal integrity but reduce the volume. TORS was a natural progression. Once we started having robotic surgery, it was only a matter of time because it was already being used for oncological work. So it was only a matter of time that it would come in. And it was very high precision surgery, so it was very, very precise, and you could deal with a lot of tissue clearance using the TORS. Then midline glossectomy, where central tissue removal to create a channel for the patient to breathe. And when the mechanical stabilization was required for posterior displacement, then tongue suspension. So based on the whether it was a volume which was to be reduced or whether the position of the tongue had to be moved forward, the surgical choices was there for us. Epiglottis again, had a huge transformation from a stage when we were postgraduates in ENT. We were always taught that epiglottis was an atavistic structure. That is a structure which is actually not necessary, but in humans, it is an evolutionarily it escaped. That was how it was taught. Because in animals, epiglottis has a distinct role. As you all know, the epiglottis approximates the soft palate. Also in newborn infants, approximates the soft palate. So because the epiglottis approximates the soft palate, the food passage is separated from the airway. So a deer can be eating its grass at the same time it can also smell its prey. Otherwise, every deer which is eating will be killed by the prey, isn't it? So it will be eating its grass, but the moment the tiger comes by the side, it knows it's come and it runs away. So this is necessary for animals. So they had to breathe when they were eating. Whereas for you and me, we stop breathing every time we swallow. So the epiglottis was considered as important animals, but not for humans, because the larynx is descended in humans. But now we know it's different. It has a role. It definitely has a role in the sphincteric function of the larynx. So functional preservation of the epiglottis became important, and various approaches for the epiglottis. Whether it was epiglottopexy, where it is fixed to the base of tongue, or partial resection of the epiglottis, or glossoepiglottopexy, where you have to suspend both the tongue and the epiglottis together. Finally, important role was that we had to preserve the function of the epiglottis. So then came the skeletal framework. Even before all this, in fact, was a skeletal framework from Stanford. It was one of the very major step forward in sleep, surgical intervention in sleep disorders. So they had come up with a two-phase protocol. The phase one was a very simple procedure where you did first an assessment, of course, with cephalometry and sleep and polysomnography, and then you had a stage one surgery where you did a genioglossus advancement. It's a very elegant surgery. In fact, Vijay will recall that was one of the first skeletal surgeries that we all did. I made Vijay do quite a few that he did, and then came the hyoid suspension. So, which was a very good procedure, very simple procedure, where you approximated the hyoid to the thyroid cartilage or to the mandible symphysis. After this, 6 months later, we re-evaluated the patient, and if they still had a significant disease burden, then the stage 2 protocol was advancement of the maxilla and the mandible. So, maxillary mandibular advancement. This is dramatic. I don't know how many of you have actually done it, but I know we have had some facial-maxillary surgeons here as well. It is a phenomenal game changer. We could see the immediate results. We had particularly one patient I remember, who was so distressed by sleep apnea. He had a retrognathia and retropercussion of the maxilla. He had a terrible time, so he could never sleep. He had only slept sitting up for almost 30 years in his life. And after the maxillary mandibular advancement, he came and told me, the first time I know what a bed means. So that is how dramatic the change was. So this is the Stanford protocol. But then even they revised, saying that you don't normally have to go through a phase 1 to go to phase 2. Because there are some people whom you know from day 1 that these are people who are going to need a maxillary mandibular advancement. So why do you want to go through a phase 1? So straight away go for a phase 2. So there was a change or a shift in philosophy even there. So the principles were, as I said, genioglossus advancement. You just move the genioglossus, so you tighten up the genioglossus muscle, it doesn't fall back. Hyoid suspension, it stabilized the hypopharynx. And maxillary mandibular advancement had the whole airway widened. It increased the longitudinal traction, reduced the pharyngeal critical peak was reduced, and very, very useful in skeletal restriction. Results were very reliable, almost 80% significant reduction in the the parameters, which was not seen in any other surgical outcome. So as I said, global airway expansion, peak reduction, and success rates were very reliable. But the problems, first of all, you need somebody who could do it. It was not an easy procedure to do. There are very few surgeons who had the the knowledge. Of course, the facial maxillary surgeons were the best people for that. And even amongst them, not everybody was interested in maxillary mandibular advancement procedure in sleep apnea. Very few facial maxillary surgeons at that time saw the merit to get into sleep medicine. Today, of course, it's changing, but at that time, we had to actually convince a couple of very good surgeons to get into it. And it changed the profile of the patient. You suddenly had a gentleman looking like Aurangzeb, the mandible was pushed forward. Of course, I thought they were handsome, they looked nice. Somebody with a retrognathia suddenly with a nice mandible, to me he looked handsome, but not necessarily to their spouses, So some of them objected. My husband looked a little different, now he's looking different. Looks like I'm married to a different man now. So that is another consideration. And of course, there's a bit of paresthesia, numbness. Sometimes it can be permanent also, and expensive. And takes about 4-6 weeks or even 2 to 3 months for the full recovery of the patient. So basically, soft tissue reconstruction was a targeted therapy for localized, problems, localized collapse, which we identified by your DICE and Vogt classification, where there is no structural problem at all. And it is also a moderate or mild sleep apnea. Skeletal reconstruction was whenever there was a significant problem with the skeletal airway and mandibular retropulsion or retrognathia of the mandible, and multi-level obstruction. So soft tissue surgeries usually have been done somewhere and failed, and they don't forget a significant morbidity. So basically, now looking at each level, at the velum, basically where we're looking at the soft palate and the lateral walls, it is mainly a surgical procedure for soft tissue. Where there is a tongue base, again you're only specifically working on the soft base, the tongue base. Where there is a skeletal formation deformity, usually you end up with an MMA if it is significant. Epiglottis, it's a targeted epiglottic surgery, from epiglottopexy to excision of the epiglottis. And multi-level strategy, you combine multiple procedures, usually a skeletal procedure with the soft tissue procedure. Ultimately, you have to adjust it to the palm endotype. So now, the clinical pearls, your 10 concise principles. You treat the patient, first of all, not the AHI. And remember, it's a dynamic airway collapse, and it's not a static event. And you have to remember the phenotype and the choice of procedure based on the phenotype. Always preserve the functional anatomy. Address all levels of collapse, not just the major level alone. Say others will take care of themselves. No. And skeletal surgery and soft tissue surgery are not mutually exclusive but complementary. You have to have an individualized reconstructive plan. And MMA is a very powerful surgical tool. And as was mentioned today by Kashmira, AI is now very much in. AI is going to integrate all the factors that you have, the anatomical phenotype, the physiological endotype, your DICE and Vogt findings, and put them all together, and then it's going to suggest to you, the best way forward. So you're looking at the phase of what we call the PAR, or the precision airway reconstruction. So this is now an important core concept. So you're going to have a functional focus, an integrated strategy, the goal of delivering the right operation to the right patient at the right time. And definitely it's a paradigm shift from where we started with a one size fits all. If you have only a hammer, everything looks like a nail. And then now to a specific precision medical model. The 5 pillars of precision airway reconstruction: anatomical phenotyping, the physiological phenotyping based on the palm model, dynamic airway evaluation basically tells you where is the collapse, what kind of collapse, a digital planning using AI, and personalized reconstruction. So take home messages: modern sleep surgery is phenotype driven and physiology informed. Excisional surgery is obsolete. Functional reconstruction is the new mantra. Treat the dominant level of collapse identified by the dynamic evaluation. Soft tissue and skeletal reconstructions are symbiotic and synergistic. You have to have a personalized approach through the 5 pillars we talked about, ensures superior long-term surgical success. And you have to have precision airway reconstruction as a new unifying conceptual framework. Thank you all. Thank you very much.
It's a great privilege to have chaired your session, sir. I thank Sankara Subramaniam for giving me this opportunity. He is a Stanleyan, where currently I am the HOD. Thanks, Stanley, also. Thank you, sir.
Thank you.
It's a wonderful talk by you, sir. Thank you, sir.
So thanks a lot, sir, for setting the entire auditorium on fire. So next will be a special moment again. Last year during the inauguration, we proudly introduced the Professor Mohan Kameswaran oration. So this year is to continue the legacy. The Professor Mohan Kameswaran oration will be given by Dr. Srinivas Kishore. I request Mohan sir to felicitate Srinivas Kishore sir with a medal.